We have got a massive stack of materials on the table today, and frankly, it demands a complete shift in how we think about human longevity.
Yeah, a complete paradigm shift.
Yeah.
It really does.
Because we're looking at the latest clinical neurology guidelines, a series of just deeply unsettling vascular pathology reports, and a wealth of recent research from the preventive medicine space.
And the data is, it's incredibly heavy. It's grave.
It is. And the mission of this deep dive is very specific. We need to completely dismantle, piece by clinical piece, this pervasive and fatal myth that a stroke is a sudden, unpredictable lightning bolt from a clear blue sky.
Yes. Because that myth, that lightning bolt idea, is costing millions of lives.
Millions.
Right. When we look at the underlying biological mechanisms, which is what we're really going to heavily focus on today, we see a very different reality.
It's not random at all.
Not even a little bit. We're looking at systemic structural failures that have been years, sometimes decades in the making.
Just quietly compounding.
Exactly. And the profound takeaway from the literature we're analyzing is that because these are long-term structural failures, they are highly predictable.
And predictability is prevention.
Exactly. Predictability is the exact mechanism of prevention. If you can see it coming, you can stop it.
Well, I want to start by just laying the raw data out, because we really can't afford to look away from the sheer scale of this.
No, you have to face the numbers.
The numbers in these epidemiological reports are staggering. Every 40 seconds.
Wow.
Every 40 seconds, somewhere on this planet, someone's brain is hit by a stroke.
It's hard to even process that rate.
It is. We are talking about nearly 6 million deaths globally every single year.
6 million?
Yes. It ranks as the second leading cause of death worldwide, and it's the undisputed primary driver of permanent, life-altering disability.
Let that interval really sink in for a second, 40 seconds.
Yeah.
As we sit here and have this conversation, multiple lives are being irrevocably altered. It's a relentless hemorrhage of human potential.
It really is.
To understand why this specific organ is so incredibly vulnerable, like why the margins for error are so terrifyingly thin, we have to look at the brain's unique metabolic demand at the cellular level.
Let's break that metabolic vulnerability down. Because when you look at the gross anatomy, the brain only weighs about 1.4 kilograms.
Right. Oh, it's tiny.
Right. That's roughly 2% of an average person's total body weight.
Right.
Yet its physiological demands are entirely disproportionate to its size.
It's an energy consumption crisis waiting to happen, honestly.
How so?
Well, for an organ that makes up just 2% of your mass, it demands a full 20% of every single breath of oxygen you take in.
20%. For 2% of the body.
Exactly.
Yeah.
And 25% of all the glucose circulating in your bloodstream at any given moment.
That is just a massive amount of fuel.
It is. You have to think of the brain as a massive, hyperactive supercomputer. But unlike a computer, it never powers down.
Right. Not even when we sleep.
Not during depth sleep, not during anesthesia, never. It requires a massive, uninterrupted fuel line because its neurons are constantly firing. They are constantly generating ATP.
Which is the cellular energy currency, right?
Exactly. ATP is what keeps the cells alive. And the brain has to generate it just to maintain a basic resting state. If you cut that fuel line, even for a handful of minutes, the neurons begin to die.
Just a few minutes.
4 to 6 minutes. And they die in ways that we currently cannot reverse.
Which brings us to a critical distinction that often gets lost in the public consciousness, I think. When people use the word stroke, they're actually referring to two radically different physiological events.
They are entirely different animals.
Right. We need to clearly define the physics of what's happening in both scenarios.
We absolutely do, because the interventions are opposite, completely opposite.
Let's start with the first type.
The first type is a hemorrhagic stroke. This is a structural failure where a blood vessel inside the brain physically ruptures. It bursts open.
So actual bleeding.
Yes. Arterial blood under high pressure pours directly into or around the delicate brain tissue.
And the skull is a closed box.
That is the exact problem. The human skull is a closed, rigid vault, so that accumulating blood has literally nowhere to go.
It just builds up pressure.
Right. It forms a rapidly expanding pool that physically compresses and crushes the surrounding brain matter.
Well, that's horrific.
It's an incredibly violent event, and tragically, the mortality rate for hemorrhagic strokes is devastatingly high.
But looking at the clinical data, that's actually the minority of cases.
It is. That's the reality. The vast majority, roughly 85% of all strokes globally, are ischemic strokes.
Ischemic. Let's break that down.
In an ischemic stroke, the blood vessel doesn't tear. It doesn't burst. Instead, it becomes blocked.
like a clogged pipe.
Exactly. The flow of blood and therefore that critical constant delivery of oxygen and glucose we just talked about just stops.
It just hits a wall.
Yep. The brain tissue downstream of that blockage is instantly starved.
And because of that immense metabolic demand, the clock is ticking immediately.
The timeline to permanent damage is agonizingly short. Like we said, cell death begins in just 4 to 6 minutes. It's a literal biological race against time.
So, as someone focused on longevity and preventive medicine, I have to ask a fundamental investigative question here.
Sure.
If the brain is this demanding, if it operates on such razor-thin margins where irreversible cell death happens in mere minutes, why on earth do we, as a society, treat an ischemic stroke as an unpredictable lightning bolt?
It's a great question.
I mean, why aren't we treating this as the end stage of a systemic vascular failure that's been broadcasting warning signs for years?
Well, we treat it like a lightning bolt because the medical establishment has fundamentally failed to educate the public on how to read the body's telemetry.
We don't know how to read our own dashboards.
Exactly. The vascular groundwork for an ischemic stroke degrades over a very long timeline.
Decades, sometimes.
Decades. The inner walls of the arteries sustain microscopic damage over years. Cholesterol and platelets build up, and the opening slowly, silently chokes off.
So the blockage isn't sudden at all.
No, the actual blockage is just the final physiological straw. It's the end of a very long process.
It's a long, deteriorating road. And what's deeply concerning, and what we're seeing all over these pathology reports, is that the body actually fires warning shots along that road.
It really does. Very clear signals.
Terrifyingly brief warning shots that are almost universally ignored. I want to dive into what the clinical literature calls the TIA, the Transient Ischemic Attack.
The clinical community sometimes refers to a transient ischemic attack as a phantom attack.
Phantom, because it disappears.
Right. Transient simply means temporary. To really grasp the mechanics of this, picture the carotid artery.
That's the main one in the neck, right?
Yes. This is the primary thick vessel in your neck that carries high-pressure blood straight from your heart up into your brain.
Okay, so it's a massive fuel line.
It is. Now, over the course of years, due to factors we'll dissect later, a fatty plaque builds up on the inner wall of this artery, usually right at the bifurcation, the point where the artery branches.
Right, where the flow hits a fork in the road.
Exactly. And because of that plaque, the channel physically narrows.
And then we hit a critical threshold. What happens then?
The critical moment occurs when that already compromised, tightened vessel goes into a microscopic spasm. Or, more commonly, a tiny piece of debris temporarily clogs the remaining gap.
There's a tiny fragment.
Yeah. For a few seconds or maybe a few minutes, the blood flow to a very specific region of the brain goes to absolute zero.
Absolute zero. That is chilling.
The brain area fed by that specific artery essentially blacks out. The patient experiences a profound physical or visual symptom.
The complete systemic glitch.
But then the vessel spasm relaxes, or the microclot dissolves or shifts. Blood flow resumes, the symptom fades completely, and the person assumes they're totally fine.
This is where the tragedy of the ignored window occurs. And reading through these case studies, it is incredibly frustrating.
It's heartbreaking, really.
Because these episodes, these profound neurological blackouts, they last anywhere from maybe 30 seconds to 10 minutes. And because they're so brief, patients routinely dismiss them.
They rationalize it away.
Exactly. They rationalize it. They tell themselves, oh, I just stood up too fast, or I didn't sleep well, or I must be dehydrated.
I just need a glass of water.
Right. But the investigative data in our sources shows something chilling. A TIA very often precedes a catastrophic, major ischemic stroke by a highly specific window.
Yes, exactly 72 hours.
72 hours.
Those 3 days represent the absolute final window where a permanent life-ending or life-altering disaster can still be averted.
It's a countdown.
It is a biological countdown. The TIA isn't just a harmless physiological glitch. It's your brain sounding a definitive, blaring alarm that a permanent blockage is imminent and inevitable if you don't intervene.
To put it in a behavioral perspective, ignoring a TIA is like sitting in your living room and having your home's fire alarm go off.
That's a great analogy.
Right. The sirens scream, the strobe lights flash for 2 minutes, and then, inexplicably, it just stops on its own.
And you just ignore it.
Exactly. The homeowner just shrugs, goes back to reading their book, and decides the house must be perfectly safe just because the noise stopped.
It's a fatal miscalculation based on the illusion of temporary relief.
You're gambling with your life.
You're gambling with the most complex organ in the known universe. And because these transient attacks slip so easily through the cracks of our daily routines, I mean, you might be in the shower, getting out of your car, or just making coffee, we have to forensically examine exactly what these biological symptoms look like.
We need to decode the red flags so listeners can recognize them the absolute millisecond they happen.
Absolutely.
Let's start with the most alarming visual glitch detailed in the literature. Warning sign number 1. The medical term is amaurosis fugax, which translates to fleeting blindness.
And the clinical descriptions of this are just terrifying.
They really are. Walk us through what it actually looks like for the patient.
Well, the onset of this symptom is incredibly abrupt. A person might just be walking down the hallway, and without warning, the vision in exactly one eye goes completely dark.
Just pitch black.
Some patients in the case studies describe it as a thick black curtain dropping down over their field of vision, or like someone suddenly smeared thick gray mud across their eye.
God, that sounds awful.
It is. They blink, they rub their face, and usually within a minute or two, the vision perfectly clears.
And it's so easy for someone over 45 to blame that on screen time or fatigue, or they think it's an ocular migraine.
Right, they find any excuse.
But let's look at the biology of what's actually happening in that 60 seconds of blindness. It's not an eye problem at all, is it?
Not at all. The anatomical pathway here is what makes this so incredibly dangerous.
Because it's connected to the brain supply.
Exactly. The artery that feeds your eye, the ophthalmic artery, isn't just some random isolated tube. It's a direct, immediate branch off of the internal carotid artery.
The same one feeding the brain.
The exact same pipeline. What causes that black curtain to drop is almost always a tiny clot or a microscopic fragment of cholesterol plaque that has physically broken off from the wall of your carotid artery.
It just snaps off and flows upstream.
It travels upward in the fast-moving bloodstream and briefly wedges itself into that tiny ophthalmic artery.
And so the retina loses power.
Yes. The retina, which is highly sensitive nervous tissue at the back of the eye that processes light, is suddenly starved of oxygen. Its ATP production drops, it shuts down, and you see darkness.
I need us to pause here and really emphasize the terrifying margin of error we're looking at.
It's paper thin.
Because if a listener experiences this and their vision comes back a minute later, they might feel an immense sense of relief. But they need to understand the physics of why they are lucky.
It's pure luck.
If that exact same microscopic clot had drifted just 2 millimeters differently in the bloodstream.
2 millimeters. That is the entire difference between a scare and a catastrophe.
2 millimeters.
If the hemodynamics of the blood had pushed that clot just 2 millimeters to the side, it would have bypassed the ophthalmic branch entirely, and it would have entered a primary cerebral artery.
Straight into the brain tissue.
Right, and instead of a 1-minute visual blackout, that patient is looking at permanent, irreversible paralysis of half their body, or the total loss of the ability to speak, or death.
That is just, it's chilling.
That's why neurologists treat amaurosis fugax like a blazing 5-alarm fire. The hospital records in these papers show a devastating pattern.
What's the pattern?
A patient ignores 2 or 3 of these transient eye episodes over a weekend, and the very next clot that breaks off goes straight into the brain's cortex.
Wow, so the eye was just the warning shot?
Exactly, it was the fire alarm.
So we've seen how a rogue clot can starve the eye. But if that same lack of oxygen hits the sensory cortex, the symptom manifests in the body itself.
Yes, moving to the physical body.
Which brings us to warning sign number 2, paresthesia. The sudden onset of what the clinical notes often refer to as drunk skin.
The presentation here is an abrupt numbness or a severe tingling sensation. But the critical identifier, the absolute hallmark of a vascular event, is that it happens on exactly one side of the body.
Only one side.
Always. It might just be one hand, one entire arm, half of the face, or an entire hemisphere of the body from head to toe.
And what does it feel like for them?
Patients describe it as their limbs suddenly turning to heavy rubber, or a dense feeling of cotton and pins that they just can't shake off.
Now, I have to push back here because we need to be incredibly precise for our listeners.
Sure.
Everyone listening to this who is over the age of 45 has woken up with a dead arm because they slept on it wrong.
Oh, absolutely. So how does a listener differentiate between a benign compressed nerve and a localized brain starvation event in real time? Because panic doesn't help anyone.
It's a vital distinction, and it comes down to the origin of the signal.
Where the block actually is.
Right. When you sleep on your arm, you're causing localized nerve compression in the peripheral nervous system. Your brain is perfectly fine. Your spinal cord is fine.
You just pinched a wire.
Exactly. You've simply squeezed a peripheral nerve in the limb. And the moment you change position and relieve that physical pressure, blood flow, and nerve conduction return, and the sensation normalizes.
But a TIA is different.
A transient ischemic attack is fundamentally different. The problem isn't in your arm at all.
It's in the brain.
The blood starvation is happening deep inside the brain, specifically in the somatosensory cortex. That's the exact region of the brain that maps and processes physical sensation for that specific body part.
And that biological mapping explains why it's strictly one-sided. The neuroanatomy dictates it. Because of how our nervous system is wired, the sensory fibers cross over in the brainstem.
So the left controls the right.
Exactly. This means each hemisphere of your brain controls and feels the exact opposite side of your body. If the left side of your brain loses its blood supply, the right side of your body goes numb.
Okay, so what if someone goes numb on both sides?
If you suddenly experience bilateral numbness, say, both of your hands evenly going numb at the exact same time, that's overwhelmingly likely to be a spinal cord or a cervical neck issue. Perhaps a compressed disc.
That makes sense. It's structural to the spine.
Right, but spontaneous, unprovoked numbness on exactly one side while you're just sitting in a chair or having a conversation.
That's the red flag.
That's a profound red flag of cortical starvation.
So vision and touch map to very specific, easily identifiable hemispheres. But the next warning sign we found in the literature is a disruption in an entirely different part of the neuroarchitecture.
A completely different region, yes.
Warning sign number 3, the cerebellar glitch. And reading the patient accounts of this, it sounds violently disorienting.
Violently is the right word. The symptom here is a sudden, extreme loss of coordination and balance.
Like being drunk?
Exactly. Patients describe developing a drunk walk without having consumed a single drop of alcohol.
Just out of nowhere.
You could be walking across a flat, completely familiar floor in your own home, and out of nowhere, your foot lands incorrectly. Your legs turn to jelly.
Or the spinning, right?
Yes. You're hit with a spontaneous, violent spinning sensation that forces you to physically grab onto a door frame to keep from collapsing to the floor.
The biology behind this is fascinating, but deadly serious. We're talking about the cerebellum, which operates almost entirely independently from the conscious parts of the brain we just discussed.
Right. The cerebellum literally translates to the little brain.
It's tucked in the back.
It sits low at the very base of the skull, beneath the main cerebral hemispheres. And its entire job is immense, continuous spatial calculation.
Like a flight computer.
Exactly like that. It uses hundreds of millions of specialized neurons, called Purkinje cells, to calculate exactly where your body is in three-dimensional space.
It's doing math constantly.
Non-stop. It dictates precisely how hard every single muscle fiber needs to fire so that you can walk in a straight line instead of careening into a wall. It's the ultimate autocorrect for human movement.
And its blood supply network is distinct from the rest of the brain, making it uniquely vulnerable to certain types of blockages.
It is. The cerebellum is fed by the vertebrobasilar arterial system.
Those run up the back of the neck, right?
Yes, these are arteries that thread up through the tiny bony canals of your cervical spine, your neck, and into the back of your head.
So if there's a drop in flow there.
If the blood pressure in that specific system drops sharply, or a microclot passes through, even for 5 seconds, the cerebellum loses its immense computational power. It glitches, it misfires.
And that's when you veer sideways.
That's when you fall. And the grave danger here is how easily adults dismiss this. They blame it on wearing new shoes, or being tired, or they assume it's just a generic inner ear issue.
But a benign inner ear issue like vertigo usually has a mechanical trigger, right? We need to differentiate this so people know when to act.
Absolutely. Benign paroxysmal positional vertigo, or BPPAV, is typically triggered by a specific physical movement.
Like moving your head too fast.
Exactly. It happens when you roll over in bed quickly or tilt your head back to look up at a high shelf. It's a mechanical issue with the crystals in your inner ear.
But the stroke warning is different.
If you experience spontaneous, intense dizziness combined with a profound inability to walk straight while you are just standing completely still, that is central vertigo.
You had to treat that as an emergency.
That must be treated forensically as a vascular warning until a neurologist explicitly rules it out.
Which brings us to a symptom that is perhaps the most horrifying to experience from the inside. Warning sign number 4, the speech breakdown.
This one is truly terrifying for patients.
The literature is filled with accounts of patients who were fully aware this was happening to them, but were powerless to stop it.
We have to be incredibly clear about the threshold here, though. We aren't talking about a tip-of-the-tongue moment.
Right. Not just forgetting a word.
No. Forgetting your coworker's name because you slept poorly or stumbling over a complex word is normal human cognitive fatigue. What we're looking for in the context of a TIA is a sudden, total, systemic failure of language processing.
And language is primarily housed in the left hemisphere of the brain for the vast majority of people. And it's split into two very distinct, highly specialized zones.
Yes, two specific zones. The first is Broca's area, located in the frontal lobe.
What does that one do?
This region is responsible for the mechanical motor planning of words. It sends the precise neurological instructions to the muscles of your jaw, your lips, your vocal cords, and your tongue.
So it's the physical act of speaking.
Exactly. If a clot starves Broca's area, you are fully conscious and fully aware of your surroundings. You understand perfectly what people are saying to you. You know exactly what you want to reply.
But you just can't get it out.
You are trapped. When you try to speak, the motor pathways fail. The words emerge as slurred, chopped, frozen syllables.
That has to be so frustrating.
It is. Yeah. The output is structurally broken, and the patient is usually highly frustrated because they know they sound wrong. This is called expressive aphasia.
Now, the second zone's failure is arguably even more disorienting, both for the patient and the people around them.
Oh, absolutely. That's Wernicke's area, located further back in the temporal lobe.
And how is that different from Broca's?
This zone is responsible for the comprehension and the semantic organization of language.
The actual meaning.
Right. If a microclot starves Wernicke's area, the physical muscles of the mouth and jaw work perfectly. The patient might speak entirely fluently with normal rhythm, pacing, and intonation.
But the words themselves?
The sentences they produce are absolute nonsense. It's a complete word salad. They might say something like, "The dog is purple on the Tuesday of the car."
Wow. And they don't know they're saying that.
Tragically, no. Because their comprehension center is offline, they often cannot understand simple, direct questions asked of them, nor do they realize they aren't making sense.
That is trisvisure.
This is receptive aphasia. If either of these profound language breakdowns occurs, even if it completely self-corrects after 3 minutes, it is a glaring TIA.
Which brings us to warning sign number 5. This one is highly non-obvious.
Very subtle, but so important.
It bridges neurology with immunology, and it exposes a silent systemic vulnerability that longevity researchers are paying very close attention to. We're talking about the clinical correlation between vitiligo and intensely unusual headaches.
Yeah, this connection blows people's minds.
Tell us about the physical symptom first.
The symptom presents physically as patches of pale or completely white skin where the pigment-producing cells have died off. That's vitiligo. It's an autoimmune disease, meaning the body's immune system has malfunctioned. Instead of attacking foreign viruses or bacteria, the immune system's T cells and macrophages are actively attacking its own healthy tissue, in this specific case, the melanocytes in the skin.
I found this link deeply concerning when reviewing the immunology papers. Why would a skin pigmentation disorder be a red flag for a catastrophic brain event? It seems completely disconnected.
It seems disconnected until you look at the systemic nature of inflammation.
Because it's traveling through the blood.
Exactly. An immune system that has gone off target rarely restricts its collateral damage to just one organ. The intense systemic inflammation that is destroying the skin pigment cells can quietly, relentlessly begin to attack the innermost lining of your blood vessels.
The endothelium.
The endothelium.
Let's talk about that layer.
It's a microscopically thin layer of cells, literally just one cell thick, that coats the inside of every single artery, vein, and capillary in your entire body.
One cell thick?
Just one. When the immune system attacks the endothelium, it causes vasculitis inflammation of the blood vessels.
So how does that tie back to the headaches?
Let's be clear on the differential diagnosis here. A new, unusually intense, throbbing headache combined with autoimmune skin changes is a massive red flag for vascular inflammation.
But not just any headache.
No. Chronic, daily headaches alone can often be traced to mechanical issues, arthritis in the neck, wear and tear of the cervical vertebrae, or an undiagnosed herniated disc irritating a cervical nerve.
Right. And that's precisely why numbing chronic head pain with daily over-the-counter pills is so dangerous from a longevity perspective.
You're ignoring the check engine light.
Exactly. You're silencing an alarm without investigating the source. You have to decode this with a specialist. But bringing up the endothelium here opens the door to what I view as the absolute core of this deep dive.
The foundation of it all.
Because the destruction of the endothelium is the foundational pathology, the root cause of almost all ischemic strokes. Everything else is just a symptom of this microscopic failure.
The endothelium is the battleground. If we want to understand how a stroke happens, and more importantly, how to prevent it, we have to understand what's happening to these cells.
The non-stick pan analogy in the literature is perfect here because it makes this highly complex microscopic biology very easy to visualize.
It's the best way to picture it.
Let's walk through that analogy.
Imagine a brand new, high-quality non-stick skillet. That Teflon coating is flawless, smooth, and incredibly slippery. Nothing sticks to it.
Right.
That is your endothelium when you're healthy and young. It's a super smooth, biologically active coating that literally secretes nitric oxide to keep the blood vessels relaxed.
So the blood just flows effortlessly.
As red blood cells, cholesterol particles, and sticky platelets rush through your arteries at high pressure, they just glide right past. But when that endothelial lining becomes inflamed or damaged, it's like taking a sharp metal fork and violently scratching the bottom of that non-stick pan.
Oh, wow. The surface becomes rough. It becomes scarred and jagged.
Exactly. And suddenly, it loses its non-stick properties. Things that are supposed to float harmlessly by, like, low-density lipoproteins, the so-called bad cholesterol, they find these rough, scarred patches, and they snag.
They catch on the jagged edges.
They get trapped in the microscopic tears. They embed themselves into the wall of the artery.
The body reacts to that, doesn't it?
Oh, aggressively. The immune system senses this, sends white blood cells to clear it up, and creates a massive inflammatory cascade. Platelets clump around the site.
Which creates a blockage.
This entire mess hardens, and this is the exact seed of an atherosclerotic plaque.
So the million-dollar longevity question is, what is holding the metal fork?
Yes. What's doing the scratching?
What are the primary assassins of the endothelium? Because identifying these dismantles the massive myth that stroke is purely a cholesterol problem.
That is such a crucial point.
You can have perfectly normal, clinically acceptable cholesterol levels, but if your endothelium is heavily scarred by other factors, you are in extreme danger.
That's the paradigm shift in modern vascular medicine right there.
Let's go through these assassins.
Assassin number one is chronically high blood sugar. And we have to look closely at the cellular mechanism here because it's not just about sugar being toxic in some vague sense.
It's about cellular starvation and glycation. Let's break that metabolic failure down. Because how does too much fuel cause starvation? It sounds like a paradox.
It does sound backwards, but here's the science. Glucose is the primary fuel for your cells, but glucose cannot just enter a cell on its own. It's too large to pass through the cell membrane unassisted.
It needs a key.
It requires insulin. Insulin acts as the molecular key that unlocks specific receptors on the cell door, the GLUT transporters allowing glucose to move from the bloodstream into the cell.
Okay, so what happens when that breaks down?
In states of insulin resistance, or prediabetes, the cells become deaf to the signal. They stop responding to the key.
So the glucose gets trapped out in the bloodstream, and the blood sugar levels steadily rise.
Yes, but think about the severe consequence for the endothelial cells themselves. They are bathed in a bloodstream absolutely packed with sugar. But because they are insulin resistant, they cannot absorb it.
They're starving while swimming in food.
The endothelial cells literally begin to starve to death while swimming in a sea of fuel. Furthermore, the excess sugar in the blood begins to physically bind to proteins in a process called glycation.
Creating advanced glycation end products, or AGEs.
Exactly. These AGEs are highly reactive and they physically damage the endothelial cells. As the cells starve and are damaged by AGEs, they lose their structural integrity.
They break apart.
They warp. They peel away from the inner surface of the artery, exposing the raw, sticky, smooth muscle underneath.
And that leads to a terrifying physiological loss, what cardiologists and longevity experts call the loss of vasomotor reserve.
Right. A healthy blood vessel is dynamic. It dilates and constricts constantly to manage changes in blood pressure and oxygen demand.
It's flexible.
But a scarred, plaque-ridden vessel that has lost its endothelial lining becomes rigid. It cannot flex. It loses its vasomotor reserve.
And when does this start happening?
The tragedy is that this destruction begins years, sometimes a full decade, before a general practitioner officially hands you a type 2 diabetes diagnosis.
Decades before.
Prediabetes, that gray zone we constantly ignore, is more than enough to quietly shred the non-stick coating of your vascular system.
That is it. I mean, it really puts prediabetes in a new light. Which brings us to assassin number 2, smoking. And we need to look at this beyond just the lungs.
We all know smoking causes lung cancer and COPD, but its effect on the endothelium is immediate, systemic, and devastating.
It's chemical warfare in the bloodstream.
Cigarette smoke introduces thousands of toxic compounds, including intense oxidizing agents, directly into your bloodstream. These chemicals cause acute physical chemical burns to the fragile endothelium.
Chemical burns inside the arteries.
Yes. They induce massive oxidative stress that neutralizes nitric oxide, immediately causing the vessels to constrict and stiffen.
And it fundamentally changes the viscosity, the actual physical thickness of the blood itself.
It does. The combination of nicotine and carbon monoxide forces your body to produce more red blood cells to carry oxygen, which raises your hematocrit.
Making it thicker.
Your blood becomes noticeably thicker and far more prone to clotting. So you have a physical scenario where you are heavily scarring and narrowing the inner walls of your blood vessels while simultaneously pumping thick, sticky, clot-prone sludge through them.
It's a recipe for disaster.
It's the perfect physiological storm for a blockage. That's why the clinical data shows smokers face a staggering 2 to 4 times higher risk of suffering an ischemic stroke compared to non-smokers with the exact same blood pressure and cholesterol profiles.
2 to 4 times. That brings us to assassin number 3. And reading through the hemodynamics research, this is the blood pressure paradox.
Yes, this one is huge.
I found this to be the most counterintuitive and frankly the most frightening piece of data in our entire investigation.
It's a critical misconception that we have to unravel. Because when most people think about blood pressure and stroke, they picture a pipe bursting. They think, if my blood pressure spikes, I'm going to have a stroke.
Right, the ubiquitous fear of hypertension.
And chronic hypertension is deeply dangerous. Let's not minimize it. It relentlessly weakens the vessel walls over decades, causing microaneurysms, and it is the primary driver of hemorrhagic strokes, the bursting vessels.
But ischemic strokes are different.
Ischemic strokes, the blockages, which make up 85% of all cases, often occur at the exact opposite end of the pressure spectrum. They happen at low pressure points.
Walk the listener through the physics of why this happens.
Yeah.
Because it means the very act of resting, of sleeping, could become the trigger if your vessels are compromised.
Okay, visualize an artery in the brain that has been quietly degenerating for 20 years due to sugar and inflammation. A thick, hardened cholesterol plaque has built up, narrowing the opening by, let's say, 50%.
That's like a garden hose that someone has stepped heavily on.
Exactly. During the day, while you're awake, stressed, and moving, your blood pressure is relatively high. That high pressure acts as a forceful pump, violently shoving the blood through that 50% narrowed gap.
So the brain still gets what it needs.
The brain still gets the fuel it needs, albeit through a compromised pipe.
But then you go to sleep.
And human physiology dictates that during deep restorative sleep, your blood pressure naturally drops by about 15 to 20%.
It relaxes.
This is called nocturnal dipping. And in a healthy person, it's a necessary restorative process for the heart. But if you have an artery that is already choked off by plaque, that normal nighttime drop in pressure is catastrophic.
Because the pump loses power.
Without the high pressure push from the heart, the blood flow through that narrowed, sticky gap doesn't just slow down. It drops to near zero.
The blood pools.
It pools, it stagnates, and it coagulates. According to Virchow's triad, which are the 3 factors that contribute to thrombosis, stagnant blood will always clot.
Right. Moving blood is healthy blood.
Exactly. So a clot forms directly on top of the plaque in the middle of the night. The vessel is now 100% blocked. The downstream brain tissue begins to die in the dark, and the person wakes up paralyzed. Or, tragically, someone else finds them that way in the morning.
Oh, God.
The low pressure allowed the biological trap to finally spring shut.
The profound vulnerability of that. I mean, the idea that the natural, vital act of sleeping becomes the final catalyst simply because the vascular groundwork was so degraded, it's unsettling.
It should make everyone take this seriously.
It forces us to confront how aging compounds this microscopic damage. We have to look at age acceleration and the strict protocol that must be followed if these warnings happen.
We have to address the age factor directly without sugarcoating it. Stroke isn't an exclusive disease of the elderly, though that's a comforting lie we often tell ourselves.
Right.
The data clearly shows that 10 to 15% of strokes happen in individuals under the age of 45.
Though those younger cases are usually driven by different pathologies, right? Like congenital aneurysms, genetic clotting disorders, or physical trauma to the neck that physically tears the artery lining.
Correct. The etiology is often different in the young, but for our listeners over the age of 45, the biology of aging shifts dramatically against you.
How fast does it shift?
Well, at a cellular level, telomeres shorten and cellular senescence increases in the vascular walls. Once you cross into your 40s, the speed at which plaque builds up and the rate at which your endothelium sustains injury from sugar, smoke, and pressure essentially doubles compared to when you were in your 30s.
Doubles, so it's compounding.
The compounding interest of vascular decay accelerates.
I want to speak directly to the listener right now. Consider your exact age. Consider what your comprehensive metabolic panels looked like 5 years ago and what they look like today.
Look at the trend.
Exactly. How are your internal fuel lines actually weathering? Because if one of these warning signs occurs, if the 72-hour window abruptly opens, you cannot rely on your gut instinct.
Gut instinct will tell you you're fine.
Human instinct in the face of sudden illness is usually denial. Instinct will kill you. You need a strict, rehearsed medical protocol.
Absolute adherence to a clinical protocol is the only thing that will save brain tissue. Step 1. If you experience sudden numbness, visual loss, or speech failure, do not isolate yourself.
Right.
Do not go lie down in a dark room to sleep it off. You must immediately get into the physical presence of another human being who can observe you and communicate with dispatchers.
And do not, under any circumstances, drive.
Under no circumstances do you put yourself behind the wheel of a 2-ton vehicle.
It's just too dangerous.
Experiencing a sudden loss of motor control or a visual blackout like amaurosis fugax while traveling at highway speeds is instantly fatal. Not just to you, but to everyone on the road around you.
You have to call for help.
You must have someone call emergency services. Paramedics can begin triage and alert the stroke team at the hospital before you even arrive.
Now, step 2 involves the blood pressure cuff, if you happen to have one at home.
Yes. If you can quickly and calmly check your blood pressure, look for the acute crisis threshold.
What are those numbers?
If the top number, the systolic, is 180 or higher, and the bottom number, the diastolic, is a 110 or higher, you are in an acute hypertensive crisis.
180 over 110.
Exactly. That extreme pressure is physically tearing at the vascular walls. It's an immediate, life-threatening red flag that requires rapid, controlled emergency intervention to bring the pressure down safely without starving the brain.
Now, step 3 is where a lot of people make a well-intentioned but potentially lethal mistake based on outdated or misapplied public health campaigns.
This is so important.
We need to set a strict, non-negotiable rule regarding blood thinners.
I cannot emphasize this enough. Never, ever swallow an aspirin or any unprescribed blood thinner during an acute neurological episode.
Explain the pathophysiology of why that's so dangerous. Because people have been taught that aspirin saves you during a heart attack, so they naturally apply the exact same logic to a stroke.
That logic is deeply flawed and highly dangerous in this context. Remember the 2 types of stroke we defined at the beginning of our deep dive.
Ischemic versus hemorrhagic.
Exactly. If you're having an ischemic stroke, a blockage thinning the blood might theoretically help break down the clot. But if you're having a hemorrhagic stroke where a blood vessel in your brain has actively ruptured and is bleeding freely into your skull, introducing a blood thinner like aspirin is literally like pouring gasoline on a fire.
You're preventing it from clotting.
You will violently accelerate the bleeding inside the brain, causing rapid, massive compression of the brainstem and almost certain death.
And there is absolutely no way to know which one is happening from the outside, is there?
None. A seasoned neurologist with 30 years of experience cannot look at you in your living room and tell you with 100% certainty if your brain is clotting or bleeding.
Because the symptoms overlap.
The symptoms can overlap entirely. The only definitive way to differentiate the physics of the stroke is with an immediate CT scan in an emergency department.
So you just can't risk it.
Do not gamble with your life by self-medicating.
While the patient is waiting for the paramedics to arrive, how should their body physically be positioned? Because hemodynamics and gravity matter immensely here.
Physics matters immensely. You should lie completely flat on your back on the floor or a bed. Do not sit bolt upright in a chair.
Why flat?
When a vessel is blocked, the brain relies on collateral circulation, tiny backup muscles to try and get blood around the blockage. Lying flat uses gravity to maximize blood flow and perfusion pressure to the brain, which is desperately trying to feed the starving tissue.
Make it as easy for the heart as possible.
Elevate your legs slightly to help push venous blood back toward the heart.
And what about the neck position?
Crucial. Keep your head strictly neutral. Do not prop it up on 3 pillows, bending your chin down to your chest, and don't let it loll violently backward.
You want a straight line.
You want the carotid and vertebral arteries in your neck to be as straight and unkinked as a fire hose to maximize whatever flow is left.
That makes total sense.
Furthermore, absolutely no hot baths or showers in an attempt to relax.
Oh, because of the vasodilation.
Yes. Sudden exposure to intense heat causes systemic vasodilation. Your peripheral blood vessels expand rapidly, causing your central blood pressure to plummet.
And if you need pressure to push past a clot,
In an already unstable brain that might be relying on high pressure to push blood past a clot, dropping the blood pressure further will immediately worsen the ischemia.
good to know.
Finally, keep a printed, updated list of your medications in an obvious place. Paramedics need to know exactly what's in your system before they administer clot-busting drugs.
Okay, so let's say someone survives this episode. Surviving it, making it through that 72-hour window without a major permanent stroke does not mean you're clear.
No, it means you've been granted a terrifyingly brief second chance by biology.
And to use that second chance, we have to look at the diagnostic protocols.
Yeah.
These are the mandatory evaluations that must happen immediately following any of these warning signs.
If you just go home and rest, you're missing the entire point of the warning.
Exactly. If you wait for the symptoms to return, you have lost the war. You must proactively hunt for the underlying structural damage that caused the TIA in the first place.
Pillar number 1 is the carotid duplex ultrasound.
We need to distinguish this from a standard ultrasound because patients often get confused about what tests they're actually receiving.
They think an ultrasound is an ultrasound.
Right. What makes the duplex so critical in a vascular workup?
A basic ultrasound simply uses sound waves to take a static black and white picture of the anatomy. It shows you the tissue structure.
It's just a picture.
Right. A duplex ultrasound goes a massive dynamic step further. It visualizes the anatomy, but it also uses Doppler technology to measure the exact speed, direction, and turbulence of the blood flowing through the artery in real time.
It's actually watching the flow.
It measures the Doppler shift of the red blood cells moving away from or toward the probe.
It shows you the actual hemodynamics, the physics of the flow.
Exactly. It allows the vascular physician to see precisely how much the plaque is obstructing the flow. It's not just about how big the plaque looks, it's about how much it's choking the fluid dynamics.
And what's the threshold they're looking for?
What they're looking for is a critical threshold called hemodynamically significant stenosis. That usually means the internal carotid artery is narrowed by more than 70%.
70% block.
If you hit that 70% mark, the medical consensus shifts dramatically. It's no longer a question of if you will have a major stroke. It's entirely a question of when.
And what is the standard intervention at that severe level of blockage?
Often, it requires a surgical fix known as a carotid endarterectomy.
What does that entail?
The vascular surgeon physically opens the neck, clamps the artery to stop blood flow temporarily, opens the vessel itself, and meticulously strips out the hardened, calcified cholesterol plaque.
Wow. They just scrape it out.
They restore the vessel to a wide-open pipeline. It's an intense procedure, but it's a profound structural reset of your stroke risk.
Pillar number 2 moves from analyzing the structural plumbing to analyzing the metabolic fuel. The glycated hemoglobin test, commonly known in the literature as the HbA1c.
This test is absolutely non-negotiable
Why is it better than just a normal blood test?
because it eliminates the massive blind spots of standard blood work. A standard fasting glucose test, which you get at a yearly physical, only tells you what your blood sugar was at the exact minute the needle went into your arm.
Right. It's a snapshot.
You could eat perfectly for 2 days prior, get a great fasting number, and still have heavily toxic endothelial-destroying blood sugar levels for the other 28 days of the month.
The HbA1c prevents you from hiding that long-term damage. Explain the cellular mechanism of how this test works.
It measures the percentage of your hemoglobin, the specific oxygen-carrying protein inside your red blood cells that has become physically coated in sugar molecules through that glycation process we discussed earlier.
The sugar actually sticks to it.
Yes. Because an average red blood cell lives for roughly 90 to 120 days before being recycled by the spleen, This test gives your doctor a mathematically precise 3-month historical average of your blood sugar levels.
You can't cheat it with a weekend diet.
You really can't.
It forces the metabolic gray zone out into the light. Let's review the clinical numbers on this because listeners need to know exactly where they stand.
An HbA1c below 5.7% is considered normal, healthy metabolism. The absolute danger zone pre-diabetes is between 5.7 and 6.4%.
Between 5.7 and 6.4.
I want to stress this. That is the exact window where your endothelium is actively being starved, glycated, and scarred, even though your GP might tell you that you don't technically have full-blown diabetes yet.
It's still doing damage.
Constant damage. Anything at 6.5% or higher is a clinical diabetes diagnosis. If you are hovering in that 5.9 or 6.0 range, your non-stick pan is actively being scratched to pieces every single day.
Which brings us to the final and perhaps most elusive diagnostic tool in our longevity stack. Pillar number 3, the Holter monitor.
This is a continuous 24-hour to 14-day wearable electrocardiogram
To monitor the heart's electrical system.
Right. When you go into a clinic for a standard resting ECG, they hook you up to the sticky pads for about 10 seconds. They capture a tiny, fleeting snapshot of your heart's electrical rhythm.
But the dangerous rhythms don't happen on schedule.
Exactly. The most dangerous arrhythmias, the ones that cause strokes, do not care about your clinic appointment schedule. They are highly transient.
The primary target here is atrial fibrillation, a fib. And the mechanics of this are terrifying.
In a normal, healthy heart, the electrical signal starts in the SA node and travels smoothly. It causes the upper chambers, the atria, to contract with a strong, organized, rhythmic squeeze, pushing blood smoothly down into the lower ventricles.
But in AFib,
But in atrial fibrillation, the electrical system goes completely haywire. Multiple erratic signals fire at once. The atria stop squeezing and instead begin to quiver chaotically.
they're just shaking.
Sometimes at an astonishing electrical rate of 300 to 400 beats per minute.
The mechanical implication of that quivering is horrifying from a clotting perspective.
Because there's no organized squeeze, the blood inside the atria, specifically in a small pouch called the left atrial appendage, does not empty.
It just sits there.
It pools, it swirls and churns against the walls of the heart. And flowing blood is happy blood. Stagnant, swirling blood immediately triggers the coagulation cascade. It forms dense, heavy clots.
And when the heart finally kicks back into a normal sinus rhythm,
It forcefully pumps that newly formed massive clot straight out of the heart into the aorta, directly up the carotid artery, and violently wedges it into the brain.
and that's a cardioembolic stroke.
That is called a cardioembolic stroke. Because the clots coming from the heart tend to be much larger than the microclots from a carotid plaque, these specific strokes are often the most devastating, causing massive hemispheric damage and high mortality.
And a person could be walking around with intermittent AFib and have absolutely no idea it's happening.
They might feel a slight, brief flutter in their chest once a week, or completely write it off as work anxiety, or too much caffeine, or poor sleep.
That's why the Holter monitor is so key.
The Holter monitor records every single heartbeat for days or weeks to catch these silent, deadly electrical storms. If a cardiologist confirms a fib, the protocol shifts aggressively to prescription anticoagulants.
And the data on those is strong.
The clinical data here is incredibly empowering. Proper monitored anticoagulation therapy slashes the risk of a cardioembolic stroke by 60 to 70%.
But I want to inject a heavy dose of reality here. And I want to advocate strongly for our listener.
We need to.
We see this all the time in the longevity space. A patient goes to their general practitioner. They sit on the exam table and say, I had this weird dizzy spell, or my hand felt rubbery yesterday afternoon. And far too often, the GP looks at them, checks their basic resting vitals, tells them their blood pressure is fine in that moment, and sends them home with advice to drink more water or reduce stress.
It happens every day.
So how aggressively should our listeners push back? How forcefully must they advocate for these 3 specific diagnostic pillars?
They must demand them. Modern medicine is an inherently overloaded reactive system. And brief, vague symptoms like temporary dizziness or numbness are easily triaged out of the danger zone by overworked doctors.
You can't just be passive.
You cannot afford to be a passive participant in your own vascular health. You must use the clinical terminology. You clearly state, I experienced a transient neurological deficit, and I am highly concerned about an impending ischemic event. I want a carotid duplex, I want an HbA1c to check my endothelial metabolic risk, and I need we to rule out transient AFib with a Holter monitor.
It's your life on the line.
If you are dismissed without those tests, you seek a second opinion immediately. Politeness will not unblock your carotid artery.
We've covered an immense, heavy landscape of biology today. Let's draw this all together and summarize the absolute core insights from these investigative materials.
The central inescapable thesis is this. An ischemic stroke is a predictable endpoint.
Predictable.
It is the final, catastrophic collapse of a vascular system that has been silently degrading for years. We outlined the 5 visceral warning signs.
The black curtain of amaurosis fugax in one eye.
The localized, one-sided drunk skin paresthesia.
The spatial glitch of the cerebellum causing central vertigo.
The structural breakdown of speech in Broca's or Wernicke's areas.
And the systemic autoimmune leak of vitiligo paired with new, intense vascular head pain.
We established the critical 72-hour window following a TIA, the ultimate biological warning shot.
We dissected the assassins of the endothelium, the cellular starvation caused by insulin resistance and prediabetes,
The profound chemical scarring and blood thickening caused by smoking.
and the terrifying vulnerability of the nighttime blood pressure drop in compromised vessels.
And finally, the 3 diagnostic pillars that must follow any warning sign. The duplex ultrasound, the HbA1c, and the Holter monitor.
The ultimate takeaway that every single listener must integrate is that waiting to see if a neurological symptom clears up is a potentially fatal gamble with your brain tissue.
Lowering your risk is not some vague, abstract wellness goal. It is a highly targeted biological mission to protect your endothelium.
You have to protect the Teflon.
You must aggressively manage your blood sugar to prevent cellular starvation and glycation, completely remove the chemical assault of smoking, and navigate blood pressure management with extreme clinical precision.
We began this investigation by comparing a broken bone to the murky, terrifyingly unpredictable landscape of neurological events. We like the clean x-ray, we like the visible fracture because it's easy to understand.
It's comforting.
But the clinical reality we've uncovered today is that the buildup to a stroke is not an invisible lightning bolt. It is a slow structural decay that leaves a massive, highly readable trail of biochemical and physiological evidence.
The clinical evidence is there in your blood, in your vessels, and in your heart rhythm. You simply must be willing to look for it before the system fails.
I want to leave you with a profound, lingering question to turn over in your mind as you consider your own longevity. We spend vast amounts of time and resources meticulously maintaining the external structures of our lives, our homes, our vehicles, our physical appearance.
Yeah, we do.
But consider this. How much of what you currently accept is just normal aging? The chronic afternoon fatigue, the slight cognitive fogginess, the minor lingering aches. How much of that is actually the quiet, terrifying sound of your internal fuel lines, slowly suffocating your most vital, irreplaceable organ?
It's a heavy thought.
The muddy waters of vascular health are actually quite clear when you look at the biology. The groundwork for your future brain health is happening right now, in this very second. It's up to you to intervene before the 72-hour window closes for good.